Welcome everyone to Inspiration Talks by Dentsply Sirona. For those of you who were unable to tune in last night to watch our first session, my name is Dr. Lisa Toms, and I'm happy to be your moderator. I hope all of you enjoyed our intro video, as this is a particularly exciting time for us here at Dentsply Sirona. We just acquired Datum Dental, the manufacturer of Osseointegration regenerative material. Actually, a couple years ago, I called Dr. Mike Bach and I asked him what we were missing in our portfolio. His answer was Osseointegration. He and many other clinicians have been using Osseointegration Plus membrane for 20 plus years with great success. While we have been distributing it in the US for some time, it's really great to officially have it in the family now. And the results clinicians have been seeing with these products really speak for themselves, as you will see today. Therefore, we have another exciting session planned for you today. Let's talk regeneration, where 3 world-class clinicians will share their amazing patient presentations and insights. At this time, I'm excited to introduce our first speaker, one of the most skilled and knowledgeable oral surgeons there is. And back when we could visit each other's offices a little more freely, I got to personally witness his surgical mastery. From my hometown of Newport Beach, California, please welcome Dr. Bach Lee.
Thank you for that introduction. I'm very honored to be here. And today I would like to share with you some tips on bone augmentation and specifically how to achieve vertical tissue height in the aesthetic zone using GBR. So most of us can attest to the difficult and the challenge that we face when we don't have enough vertical soft tissue, and especially to achieve an aesthetics result. So today, specifically, what I'd like to talk about are 2 techniques that has been very, very helpful over the years for me. And hopefully you can use these simple techniques to help achieve a better result, or at least to gain a little bit of that extra vertical tissue height. And those 2 tips involve incision design and membrane selection. And the co-relationship of these 2 concepts and how I'm able to use that to gain this little extra vertical tissue height. So, and I will do this by illustrating a number of cases from simple to more difficult cases. So when we talk about vertical soft tissue, we're really talking about bone and its underlying soft tissue. And the objective in all of our bone augmentation when we're dealing with the aesthetic zone is to try to achieve a normal buccal crest. And that's usually defined as 3 millimeters apical to the ideal gingival margin. Now, vertical defects are defects that have a low buccal crest. So defects that are more than 3 millimeters from that ideal gingival height. So when we're augmenting, ideally in the end, we would like to have a normal buccal crest, which is that 3 millimeters from the gingival margin. However, bone augmentation often can result in unpredictable healing due to resorption and remodeling. So ideally, if we can achieve a high crest, that's going to give us even a little bit more insurance in terms of our result. So ideally, when we're grafting, we want to get a high crest in anticipation of possible resorption as our little insurance. So how do we do this? Well, I'm going to share with you a number of cases and illustrate some tips and highlights of how we are doing this with this relationship between our flap design and our membrane selection. So our first case is a young gal, very attractive female with a high lip line, and she has a tooth that is failing. It's the left central incisor. You can see the fistula forming here. She's undergoing orthodontic treatment, and she's now ready to have this tooth extracted in the process of her orthodontic treatment. So you can see on the x-ray that there's a large radiolucency from her previous surgery, and you can see the scar tissue from the endodontic surgery. She's had an apical ectomy and long-standing fistula formation. So on a CT scan, you can see the large bone defect. After extraction of such a tooth without any type of surgical intervention or bone augmentation, if we leave it just to heal naturally, we can see that we're going to end up with a severe vertical defect due to the collapse of this buccal crest. I want to highlight that when we look at the thickness of this remaining bone, it is extremely thin. It's 0.8 millimeters. And the soft tissue is also thin. And you can appreciate this on the CT scan, that the soft tissue in this particular case is about 1.5 millimeters. So again, without any type of surgical intervention, we're going to have a problem. So we're going to do guided bone regeneration. So in guided bone regeneration, the first step is the incision design, and choosing the proper incision design is one of the most critical elements of the surgery. And there are a number of options that we have. We have papilla-sparing incisions, we have sulcular incisions, and we have the commonly used sulcular with distal releasing incision. Well, and the advantage of making a distal release is that it puts the releasing incision away from the graft and the membrane. And that obviously has some advantages and prevent tissue from dehiscing or wound from opening. One of the disadvantages of making a distant or wider vertical incision is that it is a little harder, more difficult to contain the graft, especially at the buccal crest. Again, remember, our goal in an objective in augmentation is to correct the buccal crest. And if we have graft that migrates away from this buccal crest, we're going to lose that ability to correct our vertical tissue height. So I propose a kind of a hybrid of these incision, and I call this the open book incision. It's an incision, essentially, I make one distal, but it's site-specific, not a distant vertical. So a site-specific vertical, the vertical incision follows the mucogingival junction and back cuts up to the apical, to the vestibule. And then a subperiosteal pouch is then released on the other side. And the advantage of this type of incision is that it allows me to contain my graft. So when I place my graft and I close this, the graft has nowhere to go except due to the apical boundaries and the boundaries of, laterally. There's really nowhere to go. It's like a pouch. It's less invasive. And secondarily, I can advance the soft tissue coronally to gain my high crest if the graft is contained. So let me illustrate what I mean. So from this graphic, you can see we do a subperiosteal releasing and this pouch. We place our graft material, and here's the apical boundaries. And when we close this, the graft has nowhere to go except for staying exactly where we have had it, where we keep it. So here's our flap design illustrated in this clinical case, our open book incision. You can see that the graft is placed, and really the graft has nowhere else to go. It cannot go apically because we put enough graft that it is well contained. We also overcorrect this to the high crest position, as you can see, where the original defect is and where the bone is corrected to. Because the flap is containing our graft, the graft has nowhere to migrate. It cannot migrate apically or laterally. The second decision that I make is the membrane. Now, it is often said that GBR is technically sensitive. Because why? Because a lot of times you can have graft migrate, you can have, trying to coordinate all the procedures with the graft and holding the membrane and tacking it down can be challenging. So this is where the advantage of a membrane selection is extremely critical. I am using an Osseointegration Plus, and the advantage for me here is that once I place my graft, I just wet my membrane and I lay it passively over my graft material to isolate my graft from my flap. The advantage here is that because of the membrane has such ease of handling that it essentially lays down without me having to place tacks or sutures and graft. Now you can secure it if you like, but I don't. And over close to 20 years of use, I have never had to tack this membrane down. And that's a huge advantage to make my surgery a lot more simplified. So I'll place my membrane over this, and then I don't need to tack this. And the membrane, because due to its cross-linking technology, it makes it more resistant to essentially degradation. And in a study that was published by Klinger in 2010, they left 3 membranes purposely exposed. And what they found was that between the BioGuide, the BioMend, and the Osseointegration Plus, after 10 days, there was only 1 membrane that was still remaining, and that was the Osseointegration Plus. Now, one of the disadvantages with some membranes when it's left exposed is that it can get infected, and it's not biologically compatible to healing of the soft tissue. What I have found over these many years of using is that it is extremely biocompatible for the soft tissue healing. So why is this important? Well, this is important because I'm going to purposely leave a small area of this exposed to encourage tissue to form into this area. So here's how we close this. We purposely leave this area exposed. And then what do we expect to fill in this area? Well, because it's surrounded by keratinocytes, we are purposely leaving it exposed to gain more keratinocytes. In other words, gain more keratinized tissue. And so what do we see over time? Because we can contain our graft without having it migrate apically, and we're leaving it exposed with the membrane over the graft. You can appreciate that we now have a high crest. Over time, what you have seen is that from where it was before to 4 months later, the tissue has granulated, and we have now more soft tissue, more keratinized tissue, vertical tissue to play with. So at this point, what we do is we essentially, you can see the before and the after CT scan. The bone is at the high crest position, overcorrected. Based on our tooth here, you can see our prosthetic tooth, we have abundance of bone vertically. So we can do implants in this situation with very little flap elevation. So we do this flapless. In my practice, when we're able to achieve this clinical scenario where we have a high crest with adequate keratinized tissue, implant is always placed flapless if we have those two conditions. So the implant is placed flapless, there's not a drop of blood after we wipe it clear, and the patient has much less pain, and there's no disturbance of this new soft tissue that we have developed. You can now appreciate the extra insurance in soft tissue that we have, the vertical tissue height that we have. This is a very easy problem to fix. We don't remove the tissue surgically, we just displace it with our provisional. So you can see the extra soft tissue. We have our prosthodontist or restorative dentist. In this case, our prosthodontist, Dr. Gianmarco O'Brien, uses flowable composite to essentially displace the soft tissue apically, and you can appreciate the gingival margin symmetry at this point. Final restoration fabricated by Naoki Hayashi, our lab technician, and you can appreciate now afterwards, because we're able to achieve a very nice buccal crest, a high crest, we are able to transform the soft tissue. Remember, the soft tissue was only 1.5 millimeters thick, but yet with no tissue augmentation, how is it now 3.5 millimeters thick? It's a concept I call bone-driven tissue regeneration. We're essentially developing the soft tissue where we're achieving tissue height and tissue width. Now, we can use this, you can see the before and the after, and you can appreciate the aesthetic, the beautiful work, the restorative work that's done by our team. Now, we can use this technology to our advantage in a little more difficult case. So this is another young gal. She's about early 20s. This is very early in 2003. I've had the advantage of using the Osseointegration Plus now for close to 20 years. And so we've been using this technique now for close to that many years. And so you can appreciate in this particular case, this gal has severe recession on this tooth that's failing, and loss of care, the recession has gone into the mucogingival junction. And so compared to the adjacent teeth, we have a lack of keratinized tissue, and we have a vertical tissue defect. And you can see here's the x-ray. Now, most people have recommended a number of ways to regenerate the soft tissue from either orthodontic extrusion, followed by either free gingival graft or connective tissue graft, and also a bone graft. And in using this, the combination of flap design and membrane selection, I'm going to show you how we are able to use this concept to correct this without doing any of this except for the augmentation, GBR. So here's our defect. The problem here is that this is a low crest. Remember we said, if we can correct this bone, the soft tissue will follow. We need to make this a high crest. So our bone augmentation is going to start first with our incision design, the open book incision. So what we can advance this soft tissue forward and strategically place our remaining keratinized tissue to allow for more keratinized tissue formation. So you can see our open book flap, our correction to the high crest position with our allograft, and the 30% overcorrection, placing our Osseointegration Plus, and you can see at this here how it's just being wetted by the blood, and it slowly just lays passively on this. Now, I will put a few more membranes over this and cover this, and then our flap design allows us to strategically place the keratinized tissue next to the exposed area, and we advance our soft tissue forward to a more coronal position. The exposed healing fills in with keratinized tissue. You can appreciate at 4 months, we have a much thicker band of attached tissue compared to the adjacent site, much more than before. So again, because we have a high crest and we have an abundance of keratinized tissue, we're able to place the implant again in a flapless fashion, simplifying our surgery. Here's our before. You can appreciate at 3 months, you can see the keratinization occurring over the ossix and the bone graft. And at 4 months, we place our implant flapless, place our provisional restorations, and our final restoration at 1 year after maturation of the keratinized tissue. And here's at 3 years. You can appreciate without having to do any adjunctive soft tissue procedure. And lastly, I would like to share with you, sometimes we may have very challenging cases where we have to augment vertically significantly. This is a single tooth defect that has undergone a failed bone graft, referred to me. Now, in this particular situation, this is a significant, probably a 6-7 millimeters of a vertical defect. Now, we can probably gain maybe 3 millimeters, and we're going to use a combination of crown lengthening, gingivectomy, and advancing the soft tissue vertically by about 3 to 4 millimeters to balance this out. You can also appreciate we have a loss of papilla due to bone loss to the adjacent tooth. A very challenging case in a patient that has a very high smile line. So our goal again is to balance the gingival margin by doing a combination to create essentially symmetry. We're going to do gingivectomy and crown lengthening on the right central and advance the soft tissue, creating a more balance. So here's our crown lengthening, our open book incision, our allograft, mineralized allograft. We lay softly or passively our Ossix Plus without tacking, and then we advance the soft tissue again coronally to create more balance between the two. As you can see, this is at 3 months of healing. The papilla is still short on this side. At this point now, at 4 months of healing, with our provisional restoration, we go in and place our implant. We do a little touch-up of gingivectomy to create more symmetry. And here's our provisional restoration placed on our implants. You can see before and after. At this point, we do a little bit more modification of the provisional to create a little bit more grooming of the soft tissue to create a little more balance. And this is done by our prosthodontist, Dr. Gianmarco O'Brien. And you can see after about a period of 6 to 8 months of provisional restorations, the soft tissue has matured. We have our final abutment and final restoration fabricated by Naoki Hayashi. And here's our final restoration. And you can see the smile line and our final restoration now at 5 years. And you can appreciate the soft tissue symmetry and the creation of keratinized tissue. So I'd like to conclude by sharing with you the concept of flap design and membrane selection and how that can be used strategically to gain soft tissue and to gain vertical tissue height. So I thank you for listening, and I hope that this helps in your surgical results. Thank you.
Thank you, Bach, for that wonderful presentation. I do have a couple questions for you. So when you look at your CBCT for pre-planning, how often would you say you run into surprises when you actually open the flap and it looks different than the CBCT findings?
Great question, Lisa. The CBCT scan for me has been extremely helpful, especially for bone augmentation, especially for immediate implants. And I would say that as you know, the data that you put into it is the data that you're going to get out of it. I would say that it is very accurate in my experience. And I think that sometimes when we are only looking at one slice, we can often see distortions because of either overlap or maybe the slice is cut in not the acquisition points that we want. So, for example, I'll give you an example. Sometimes, people will say that the incisive canal is, it's so big here and it's in this image and it isn't really there. Well, that's because sometimes the cuts are made right through the incisive canal. So you see it and it gives you the impression that the available bone is a lot less. But yet, if you go back in and I draw the curve to the exact acquisition point that I want to see, then I find that it is quite accurate.
So also, I've spoken to some surgeons who've had some difficulties with apical migration of the graft. I'm curious to know the story behind how you came up with this great open flap technique so long ago.
We played around with a number of flap designs And we found that there is no perfect flap. There is nothing, the world is not black and white. Every flap has a good and a bad, a disadvantage and an advantage. So many people will say that making a site-specific vertical, gets in the way of your graft and your membrane. It can cause problems with healing. Yes, with certain membranes, but with the Ossex Plus, as you can see, we can leave it exposed. So we are able to take advantage of the membrane and using a flap to essentially contain the graft and using the membrane to encourage improved soft tissue healing.
Yeah, all the parts have to come together and they all have to be done properly, and you do that so well. To add to that, your aesthetic results are beautiful. I've watched you for years present, and so I know there's not an easy, quick answer to this, but how have you developed that relationship with your restorative clinicians?
That's a great question, Lisa, and that was something that has been in the works for many, many years. I've been very fortunate. There's so many good people around that I have been able to learn from. And I think it was Larry Breck that I learned this from in one of his prosthodontists at NYU. He said that learn and be an expert, or at least become an expert in the other person's expertise or specialty. Now, I would never become an expert in prosthodontic or restorative dentist, but I try to do the best that I can to improve my knowledge in other people's work so that when I do communicate with them, I'm able to at least talk at their level, and they appreciate that. And that's how we all improve, and we pull each other up by all of us up, the team up together. And that's how we're able to achieve it. I couldn't do this all by myself. It's really a team effort.
Fabulous advice. And like I told you, I feel like I could do a flap now watching you, but I know I can't, and I'll stick to pros. So thank you. Thank you very much for your time today. I really enjoyed it.
Thank you so much, Lisa, for having me.
And now we have our second speaker of the day, Dr. Rodrigo Neva. So I was having lunch with Dr. Neva at an Academy of Perio meeting a while back, and I felt like I was sitting with a rock star because so many people came up to our table to ask him questions and to thank him. So Dr. Neva will share his patients with us, highlighting Ossex Volumax. Joining us from the University of Pennsylvania, please welcome Dr. Rodrigo Neva.
Thank you for that wonderful introduction, and thank you for having me. Today, I'm going to be talking about absorbable scaffolds for the correction of buccal concavity defects. So what do I mean about buccal concavity defects? I'm talking about this aesthetic deficiency that is caused by tooth extraction. This is something that we try to minimize with ridge preservation, but we can't completely eliminate. This creates an aesthetic problem for the implants that we're placing. I'm not talking about the buccal concavity defects that prevent the placement of a dental implant. I'm talking about that buccal concavity defect that creates this aesthetic challenge for us to deliver a high quality aesthetic case for our patients. So what can we do? What have we done to manage this type of buccal concavity defect? We have addressed this basically two ways. We have done an additional bone graft, either at the time of implant placement or at second stage surgery, to create this ideal contour. We've called this a contour graft. And we have also tried to create additional soft tissue thickness to mask that buccal concavity defect and create a more aesthetic implant case. What we have also tried to do over the years is to look at alternative materials to correct this type of problem. So we have used a cellular matrix, for example, but we have also tried to look at some collagen constructs for that purpose. Collagen constructs have a great advantage over autogenous tissue or additional grafting because collagen structures, they are composed of collagen, which is a natural component of both hard and soft tissues in the oral cavity. But these collagen structures that we have used in the past, they have failed to provide long-term results. It's something that, based on the nature of the collagen that was used for this purpose, it's something that created a significant volume for the first couple months, but this tended to go back to original volume over time. So not a very predictable treatment long term. So what options do we have to treat this type of buccal deficiency or buccal concavity type of defects? Well, in recent years, we have also seen the fast development of absorbable scaffolds for bone regeneration. So these absorbable scaffolds are very different than the bone grafts that we have used in the past. They're nothing more than a collagen matrix that is specifically designed for the formation or the regeneration of alveolar bone. And this is something that has totally changed the way I look at site preservation or implant site preservation or the management of extraction sites. So instead of using a conventional particulate material in extraction sites and having to worry about the turnover rate of this graft material particles, which could potentially affect bone quality in the area, I've been using this type of collagen construct for this purpose. And the great advantage of this type of collagen structure is that since it's a fully resorbable scaffold, this scaffold will resorb and will be replaced by new bone, leading to higher tissue quality in the area. So if you compare like from before and after, and this is a 4-month re-entry on that site, you can appreciate that ridge dimensions have been properly maintained, but we have a very acceptable result now, or a very ideal site for implant placement. So very interesting technology for bone formation. This same technology has been used now for the development of another scaffold to help with soft tissue development. So is this a soft tissue scaffold, or is this an absorbable soft tissue scaffold? What is this? This is a multi-layer membrane-like material that can be either used as a single layer or can be used as a double layer. So I've decided to use this as a double layer based on what I have learned from this, the same material in that sponge form for bone formation. Well, if that sponge is capable of forming or allowing bone formation, if I have this folded in half, I would basically try to address the problem from both angles, from the bone side as well from the soft tissue side. So that's the rationale for this type of absorbable scaffold for treatment of buccal concavity defects. That being said, my first experiences with this were related to immediate implant placement. So here I have placed an implant, have ideal primary stability. I have a gap between the implant and the socket walls, which I'm filling with a particulate material, in this case here, a cancellous-based allograft. But I'm still worried about the contour and the potential changes that will happen on that buccal plate. So instead of only using graft material, I'm using the graft material inside the residual socket, and I'm covering with this scaffold on the buccal aspect of the ridge, so buccal to where the bone was. Closing the area up and letting this heal, and being very impressed with this over time, because this is a 4-month follow-up on this case. And I can see that the contours have been properly maintained. Color match here is very ideal. And if you look at your picture on the right, you can almost see that that scaffold is still present. And you can almost visualize where that is with flash photography, something that you wouldn't be able to see normally if this patient was walking down the street. But with flash photography, we can see that the material has been stable for all this time. So very different to the other collagen materials that we have tested and used in the past. So with this, I've decided to then apply this to the development of this buccal concavity defects at second stage surgery. Why at second stage surgery? Because I believe that at second stage surgery, we have all the tools that we need to achieve proper soft tissue development, because we don't have to worry about an implant integration anymore. That implant has been completely integrated at this point. You tested at the time of second stage surgery. And now we can focus on that soft tissue development, on that aesthetic development of the area. So as you can see here, we have an implant that's completely covered by bone, but a thin layer of bone. And we also have this concavity that is formed by the presence of two adjacent teeth, which have much more buccolingual dimension than that implant body has. So instead of putting a bone graft material or putting on a tissue graft, all that I did here was simply folded that scaffold in the middle, so double layer it, and intentionally place it away from the defect or away from bone, sort of like to create a retaining wall facial to that implant. What is the idea behind this? The idea is to still have a viable blood clot in between bone and this dual scaffold, and having this inner layers of the scaffold help this blood clot that formed there to potentially ossify, while we have the outer layers of the scaffold helping with soft tissue development. Because since this is a multi-layer construct, these layers will eventually start to separate and create an effect of tissue expansion over time. How long does this take to happen? Well, on a situation like this where we have a defect that has low regenerative potential, as we all know, this is a one-wall type of defect. This is a process that may take anywhere between 9 to 12 months to fully complete. But what we see on the right is the immediate effect of the volume that is being achieved by the placement of this material. This volume is then altered and changed with the use of provisionals, creating a much more aesthetic soft tissue contour for better emergence profile of the restoration that will be placed there. So this is very similar to what we would have done with either a bone graft or with a tissue graft that we had placed in that area. So what's very interesting is to then look at this site over time. Not only we have seen stability of the static case that we created by the use of this absorbable scaffold for this purpose, but what is also very interesting is to look at this over time on a CT scan to see what's really happening, because it's interesting enough to have stability of the ridge contours for aesthetics, but it's even more interesting to look at the CT scan and identify now a much thicker buccal plate than we had when this material was placed. So this to me was a big eye opener and has really changed the way I look at this type of defect. So this became a protocol. This became my go-to material for this type of situation. Placement of this dual layer or this dual scaffold as a double layer at the time of second stage surgery. And with that, we have also I have also follow up some of this case for up to 3 years. And specifically this case that I'm presenting here, I can show you what this looks like 3 years later. This is, to me, it's a huge game changer in the management of this type of buccal deficiency, buccal contour deficiency that we have seen in implant dentistry. Because at 3 years, not only we see that stability of that, but we see additional mineralization and creation of a much more natural contour for that ridge. You can see the additional ossification that happened within this construct that has maintained this stable over time. So this is very interesting, very fascinating, and something that I believe that completely changed the way we look at this type of static challenges that we have in implant dentistry. And as I said, this has become the norm for this type of situation, either at the time of implant placement or at second stage surgery. The great advantages of this is not only the high static result, but also the stability of the case over time. How much of this scaffold will actually become bone? I think it varies a lot from case to case, depending on the nature of the defect. The deeper the concavity, probably the greater the chance for mineralization. But mineralization here is not the main goal. The main goal is to address the static problem and create a much more ideal site for an aesthetic implant restoration. So it's almost like If you have mineralization, great, that will give more stability to the site long term. But the main goal, which is to create an aesthetic case, can be easily accomplished with the single use of this type of dual absorbable scaffold without the use of any additional grafting materials or anything like that. So this is what I'd like to share with you today. Hope you can submit your questions or have submitted your questions, and I'll be glad to answer them now. Thank you.
So thank you, Rodrigo, for that fabulous presentation. And I do have a few questions for you. So I've noticed over the years, many patients with the replacement of their maxillary laterals have this shadow up above the restoration when they smile. How do you kind of explain to the patients the need for both hard and soft tissue augmentation in these areas?
Well, I think that this is something that we have to discuss with our patients very often. Patients come to us because they want a tooth, but they forget that when they're missing a tooth, they're also missing the bone anchor, which is the dental implant, as well as both hard and soft tissue. So without creating an ideal hard and soft tissue profile, it becomes very difficult for you to achieve an acceptable aesthetic result. And if you correct that hard and soft tissue with something that does not give you long-term stability, chances are that after a couple of years in function, the neck of that dental implant will start to show and will become an aesthetic. So not only it's important to correct the missing hard and soft tissue, but also correct it with something that will give you long-term results.
So I've heard that you just love the Profile EV implant, and I also saw UPenn came out with a study in JOMI just recently. There was a study of the CBCTs with sloped ridges and how often that is a good implant to use. Why do you like that implant so much?
Well, Lisa, the reason why I like that implant so much is because it's very hard for us to find a bone profile that is flat. Over the years, we have either decided to flatten the bone surface to accommodate the flat neck that all implants have, or we have added additional materials. We have to graft the site to make up for the buccal aspect of the ridge, which is usually lower than the lingual aspect of the ridge. So with Astra EV profile, since we have a slope neck, we can adjust that to the patient's anatomy and provide a much more natural replacement for that missing tooth. And with that, we minimize the need for grafting and we simplify treatment for the patient.
Thank you so much for your time today.
You're very welcome, Lisa. Thank you all for everyone for attending, and I hope you all have a great meeting. Thank you.
At this time, I'm happy to introduce you to our final speaker of the day, Dr. Matt Fien. I haven't visited his office in Florida personally, but I have been following him on Instagram for quite some time, and his everyday clinical work is amazing. Joining us from sunny Florida, please welcome Dr. Matt Fien.
Hi, Lisa. Thank you for that incredible introduction. I'm super excited to present some of my cases in this session. We're going to be talking about Osseointegration bone, which is a mineralized collagen sponge that we can use for a wide variety of procedures. As you can see, Osseointegration bone comes in 3 different sizes. And at first glance, it really looks very similar to a lot of the other socket grafting materials that are out there, collagen sponges and things like this. And if you start to handle this material, you really start to see how different this material is. When a typical socket plug gets hydrated, it gets very, very mushy very, very quickly. This material is really very, very different because it comes in almost a chalky consistency. And the way that we use it, which I'll show you in detail, is by hydrating it in the patient's blood. So it's a mineralized collagen sponge that's composed of porcine cross-linked collagen interspersed with hydroxyapatite. And so this really allows for this great environment for vascularization of our bone graft materials. And it also allows us to keep that space maintained while that blood clot and that bone graft has a chance to mature. Now, the science behind this product is really drives the success of this material. This is like I mentioned, cross-linked collagen, and it's cross-linked using a glymatrix technology, which basically means that we're using naturally occurring sugars, ribose in this case, to cross-link the collagen. And so this really enhances the durability of the material and the ability of the material to turn into regenerated bone. It comes in 3 sizes. This has really been my go-to, this 5x5x10. And actually I use this same size in each of the 3 cases that I'm going to show you today. We've already maybe have heard of this glymatrix technology. If you've ever used Ossix Plus before, or Ossix VoluMax, 2 of the other products in this Ossix portfolio. Both of those products are really been the mainstay of my regenerative procedures. Ossix Plus as a very thin collagen membrane that's super resistant to degradation. And then Ossix VoluMax, which is a 2 millimeter thick collagen scaffold that we're using for some sockets, but also as a scaffold in cases where we don't add bone graft material, we're still able to regenerate lost buccal plates around implants and to really thicken up the soft tissue. And because of this cross-linking technology, we know that this material is actually mineralizing over time. And so it really makes sense for Datum, the manufacturer of these Ossix products, to have come out with a bone graft material. And this material is what we're really going to focus on today, this Ossix bone material. As you can see, when you're using this material, it looks much similar to a lot of these socket materials that we've used in the past. But like I mentioned earlier, this material will actually be super resistant to degradation and will stick around long enough for the body to regenerate bone in its place. But it's very important when you're handling this material to get a feel for the material first. So that's what I'm going to try to do in the next couple of slides, is just basically show you my advice in terms of handling things that will improve your long-term outcomes. We all know for simple sockets, the most important part of that procedure is probably to degranulate completely and get some nice bleeding in that socket. We then insert the Ossix bone into that socket completely dry. And what you'll notice is that this material is very hydrophilic. And so the blood from the socket will quickly infiltrate into this material. And then all of a sudden it goes from this chalky type consistency to a much more spongy consistency. And it actually will expand as it gets hydrated. The next step is usually when we're placing a bone graft would be to pack this material really tightly. And I think it's very key for us to realize the benefit of this material is that it has that nice spacing for vascularity and for angiogenesis. And so while we're going to place this material at the original crest of bone, we're not going to really strongly condense it into the socket, because we like the space and that environment that it creates for new bone formation. So I'll use the back end of a periosteal elevator, or I'll use a condenser with just some gentle force just to get that material right at the level of the crest. And that's really going to be key, not to overpack this material. And remember, because it expands, it's really nice for the sockets, because at the apical extent of the socket, it's very easy for that material to expand and fill those voids, so you don't end up with any dead space. This part of the procedure is my favorite, because rather than doing any sort of fancy suturing, we can really do the most simple possible suturing just to allow the soft tissues to passively close. And as you can see here, I left this case open probably 4 or 5 millimeters because I'm not putting any tension on the flat margin. And there's a lot of different ways that we could suture this material. Like I said, single interrupted. You can use a figure 8 or a reverse mattress. But the nice thing is, because I can use this material in a lot of cases without using the addition of a membrane, I don't have to worry about me pulling or biting my membrane out of the socket. So that really makes it much easier for us to manage sockets and not have to complicate cases that really have very simple solutions like I'm showing you. One of my biggest pieces of advice for you, if you've never used this material, is not to handle the material too much when it's dry, because like I said, it is very chalky and it will tend to start breaking apart on you. The first time you use this will undoubtedly happen. Just know that's okay. It doesn't matter if it crumbles. You can still use it just as you would if it wasn't crumbled. I just think that the benefits of the material are that you're not dealing with a particular graft. And so it's nice when it stays together, and there's just a lot less manipulation that you have to do. For sockets that are intact or nearly intact, a 3, 4, 5 millimeter distance even, I'm finding that we can use this material because of its nice space maintaining properties without the addition of a collagen membrane. And so that's really very, very nice and really simplifies the procedure for us. Let's look at a case from start to finish, one of the first cases I completed. And this is a typical case where I would love to place an immediate implant, but for financial reasons, that wasn't in the cards for the patient. And to be honest, it was a little bit of a relief because as you can see, there's very little bone apical to that socket for me to get good primary stability. And so what we'll do is just like in the previous case, after fully degranulating the site, we'll place our Osseointegration bone passively into the socket, and you'd be surprised how quickly that blood will just seep through and make this material bright red and spongy. At that point, like in the previous case I showed you, we'll just gently compress this material so that it's right at the level of the crest. And then again, some chromic gut resorbable sutures just to passively get closure, maybe help keep that material in place just a little bit. Now, this is great because that shows perfectly at about 2.5, 3 weeks, how despite not having any primary closure here, because this material is so biocompatible, we have some nice closure. We have secondary healing here. And most importantly, we have this beautiful band of thick keratinized tissue now at 4 months when we're ready to place our implants. At this point, you can see I placed a crestal incision and I exposed the alveolar crest, and you can see here how I can place my implant in that perfect ideal position with all that beautiful remaining bone that I have. And as you notice, very little remnants of any particulate bone graft material. Now, I love showing this picture because this patient did have a very high and wide smile. And so she was wearing a partial, and it was very important to her that no one ever saw her without her teeth. And so when I placed this implant, I actually decided to just bury it and let her wear her partial so I wouldn't have to do many adjustments there. And I just thought it was so interesting because I did not bury this implant subcrestally. This implant was placed right at the level of the crest. And when I went back to do the uncovery about 3.5 months later, you can clearly see that we have new mineralized material, mineralized bone material over the neck of that implant. And so it really tells you how this material continues to mature over time. And in a case like this, where I previously maybe would have used a particulate bone graft with a resorbable membrane, raising maybe bigger flaps to get access, I'm able to complete this and get really good predictability in a very, very simple fashion. Now, sockets can be treated a lot of different ways, but I just think it's really important for all of us to appreciate the benefits of not raising big flaps and doing minimal treatment, or I should say minimally invasive treatment when possible. Because as you can see here, we didn't move the mucogingival junction. We have this beautiful increased zone of keratinized tissue, and we're really preserving the blood supply to the buccal plate by not elevating the periosteum. So we all know that this is really a great way to go. Of course, a lot of the cases that present to my clinic, and I'm sure yours as well, present with a lot more complicating factors. So here's another case of a little bit more advanced socket grafting, where the patient presented with a buccal fistula that was draining. She had quite a bit of swelling and discomfort. And taking a look at the x-ray, you can see we have a tooth with a history of a root canal and a recurrent periapical radiolucency. And in these cases, like I mentioned in the last slide, I do try to keep things minimally invasive. So we'll extract the tooth without a flap, and then we'll go ahead and start degranulating and bone sounding to see where the buccal plate is. Of course, in this case, it wasn't so simple because this defect really started to expand as I got more apical. And as you can see here, we had quite a large fenestration. And in these cases, I just prefer to place a vertical incision because I really find the most important part of the success of these procedures is going to be completely degranulating these areas. And so by raising a little bit of a larger flap here to get access to that defect, I can be 100% certain that I've completely degranulated the area. I'll go ahead and take that 5x5x10 Osseointegration bone, place it into the socket, just like in the previous case. And you can see I have some great bleeding here. So this is really going to quickly absorb all of that blood. And soon enough, we'll have a situation where now we have the entire socket filled. I'm not really too worried about dead space because I know this material expands once it gets hydrated with the blood. But because of the large defect here, I went ahead and put an Osseointegration Plus membrane right over the top very simply. And this just lays right over the top and conforms really well to that defect. Again, I do not want to get primary closure in these cases if I can avoid it, because then I have to worry about changes to the soft tissue. And so I feel very comfortable using this combination of materials and leaving it slightly exposed. So no fancy suturing. These are PTFE sutures, but again, we're not looking for primary closure. We're going to let biology do most of the work. And at 4 months, you can see we have this really nice, beautiful band of thick keratinized tissue. I'm able to place my implant in that ideal position. And here's an x-ray from the date of the implant procedure. And so a lot of my cases as a periodontist, I'll perform the implant, I'll perform the uncovering, and the patients disappear for quite a while. And I was lucky enough to see this patient in the office just about 2 weeks ago. So I was able to get a really nice follow-up. Regardless, here's the final post-op appointment with my patient where I performed the uncovery right after taking this radiograph. And now here's the 2-year post-op of the case restored. And you can see we have beautiful, healthy keratinized tissue. And the x-ray revealed really stable bone results. And as you can see with the dates here, we're about almost 2 years post-op. And so this was really a nice result for a case where I really had a challenging defect to work with. Luckily, I had that bridge of bone, which really made me feel comfortable that I can go ahead and use something like Ossix bone that will maintain the space, and then Ossix Plus over the top, just to help keep that material confined to the space and maybe exclude some soft tissue cells from growing into my defect. Okay. This scenario is the last scenario we're going to talk about, and it's something that we see every single day, placing our implants in situations where we have marginal amounts of buccal bone. And in this case, if you look closely, you can see I really had an unmeasurable amount of buccal bone here, probably less than 0.5 millimeter. And in years past, I might try to do some particulate bone grafting. I might try to do a ridge split, but I really am always looking for the easiest, most simple solutions that are also going to give me the most predictable results. And so really harnessing the benefits of the handling of this material, rather than having to use particulate, I can use this Ossix bone, place it right into that buccal concavity. Again, you can actually see here very nicely how I probably manipulated that material a little bit too much when it was dry as it started to break. Like I mentioned earlier, there's no reason to fret that situation. You just go ahead and continue on, leave that material in place. And because this is more of a ridge augmentation case where I really want this material to be stable, I will go ahead and, again, use that Ossix Plus membrane over the top, excluding soft tissue cells, but also confining this material to the defect. Now, a lot of the times you'll see in my cases that I'm using periosteal stabilizing sutures. This is not one of those cases. This is just a simple horizontal mattress suture. And what this suture is doing is it's allowing me to coronally position the flaps a bit and really take tension off those flap margins. And at the same time, it is sort of holding my membrane down over my bone graft, but it's not a complicated suture, and really it's just meant to keep tension off of my flap margins. You can see that allowed me to get really nice closure with very little tension on the flap. And then this is the 4-month post-op where the patient returned and we were ready to do our uncovery. At that point, we did take a cone beam CT scan, and it was really very nice for me to see that this material was clearly mineralizing buccal to the implant. This was about 4.5 months. I did my uncovery and I had to get a stud finder to find my implant. And so that's really something that we start getting used to when we're using these materials that are so biocompatible, that are actually mineralizing themselves. And you can see here, after exposing the implant, I clearly have obtained about 3 to 5 millimeters of bone buccal to this implant. And prior to this procedure, again, I would have been using particulate graft. I would have been using a combination of different materials to obtain this result. But you can clearly see here, this is a very simple protocol to perform contour augmentation, which is not always so easy to do. This is another case where I was recently able to get a great post-op on the patient. So you can see here, this is the about 2.5-year post-op where the patient's really doing very, very well. She has nice, healthy tissue. And I even have a final radiograph from about 2.5 years. If you noticed, in the meantime, we ended up having to do an additional implant on the maxillary left canine, but stable results at both sites, now 2.5-year post-op. So this really gives me a lot of confidence starting to use this material in a lot broader indications. I think the trickiest thing with any material is, choosing cases to start with that are simple, that allow you to get a really good feel for the handling of the material before you start using it for more aggressive cases. But I really encourage you all to give it a shot because I've been having some great results. And so thank you very much for inviting me here to share some of my experiences with this great material. And I hope to see you soon.
Thank you, Matt, for a great presentation. I really loved how you had to use the stud finder to find that implant under all that bone. So I have a couple questions for you. So I know some products use glutaraldehyde for a cross-linking method. How does that compare to the ribose?
That's a great question because, of course, we like to break down membranes as, either native collagen or cross-linking. And we start thinking that just because a membrane can be labeled as cross-linking, that they're all the same. And what you'll see if you use these products that are sugar cross-linked, you'll find that the resistance to degradation is really very strong, very long. And so you can leave these membranes exposed and still feel very comfortable that you're going to obtain really good bone underneath, at the same time that they're very biocompatible because they're cross-linked with sugar, which of course we know is found throughout our bodies. On the other hand, I've tried to use a variety of different membranes that are cross-linked with things like glutaraldehyde, and you consistently see that they break down much quicker than Osseointegration Plus, and there's also a more of a local inflammatory reaction. So hands down, I don't think you can compare the two.
Makes perfect sense. Thanks for that great explanation. Next question. So both you and Dr. Lee spoke about the apical migration of bone grafts and how you prevent those. So you both use the Osseointegration Plus membrane to do that, to secure the graft. So how long have you been using the Osseointegration Plus membrane?
As crazy as it sounds, I've been using it since probably the first year of my perio residency. I just recently went back and looked at old cases, and I have some cases from back in 2006. So now we're talking about maybe 14 years, almost 15 years.
That's what we like to hear, long-term results. You mentioned surgeons should find a really simple case for their first Osseointegration bone experience. What would that be in your mind?
Anytime you're bringing a new material or a new technique back to your practice. And so for Osseointegration bone in particular, I would really look for a case where you have a socket that you can be very confident is completely cleaned, preferably one with, a buccal plate that's intact or only a mild buccal plate dehiscence. And then you can kind of practice handling the material, just like I showed in my cases, laying it into the socket, letting the body and the blood fill into that material, letting the blood absorb into it. Takes about 30 seconds to a minute in most cases. But just kind of watching that happen really is going to improve your ability to understand how this product handles and how it kind of expands a bit. So then you can start using it for some larger cases, some of the larger socket defects, like the example I showed you, and even some ridge augmentation cases.
Love it. Well, thank you so much for your time today. Really appreciate it.
Thank you, Lisa. Thanks for having me.
Thank you all for attending today's session. And thank you again to our wonderful speakers, Drs. Bach, Rodrigo, Neva, and Matt Fien. I've truly enjoyed spending the last 2 days with you, and I hope you found the presentations valuable. If you have any questions or would like to talk to the company, please visit our e-booth throughout the meeting. Our representatives would love the opportunity to talk to you. Thank you again, and enjoy the rest of the meeting.